I don't know how relevant this talk is in this course of events. So we've come to understand a lot about cross-linking in this last couple of decades. And this is just a talk which is going to summarize the directions which you have gained and the controversies which are still abounding. We are all aware that there is this prevalence of keratoconus of 20 in 10,000 eyes, and there are various factors which are associated with this occurrence with a male preponderance. We also know that today we stand with sound grading systems which are help us identify keratoconus. We also understand it essentially a biomechanical weakening wherein there's a disruption at the layer of Bowman's layer with collagen fragmentation, fibrillation, and fibroblastic activity which triggers it, and cross-linking, especially with the type 2 anaerobic cross-linking, where there is nascent oxygen is released, which helps in bringing out active cross-linking, seems to be the way to go. We are all very familiar with the Dresden's protocol, which has been the standard answer for a good cross-linking. But then different challenges rose over the period of time. Like when we were stuck with thin corneas, there were these three options which opened up, wherein if you were supposed to use a hypoosmolar riboflavin, the first half an hour you would hydrate with the isotonic riboflavin solution, and then the last 10 minutes you would use a hypotonic solution. But then, although the efficiency was there, the intraoperative time was more, and then the cross-linking was not very effective because of the lower concentration of collagen in the hydrated stroma. Then again, the transepithelial cross-linking was graining footage, and probably it had a role to play. But again, comparison showed that the stromal regular standard cross-linking was way better than the transepithelial. And more importantly, we also got to know what's not moving. Sorry. Very sorry. Very sorry. We also got to know that although there was no scarring was evident, and 23% of the keratoconus eyes actually progressed in the transepithelial group. So then the thoughts came, do we increase the contact time by using a more viscous solution? Do you change the permeability of epithelium with better back and EDTA? Would you change the physiochemical properties of riboflavin, and so on and so forth improved? But then it continued to show that the demarcation line with transepithelial PRK was far more superficial than the standard cross-linking. Then we looked at the contact lens cross-linking, and we found that there were problems because the riboflavin does get entrapped in the precorneal space. The absorption properties of the contact lens is definitely different from stroma. Not to remember that the buckling effect of the cross contact lens during procedure. So then the tailored stromal expansion with the smile lenticule seemed to be more promising and more physiological. Well, all this was happening, there came an understanding of why not move to accelerated cross-linking, because we all knew that the photochemical effect should be similar as long as the total fluence was constant. So therein came in a whole range of protocols to play around with. But when we compare two procedures, we need to understand it in all its different presentations. Yes, we understood it was safe, more so with the 3 millimeter and the 9 milliwatt cross-linking. We looked at the visual acuity. It seemed to be not statistically significantly different, but there was a trend for the 3 and the 9 milliwatt protocol. When you looked at the keratometry, again, we found the flattening was most optimal in the 3 milliwatt and became little lesser with 9 onwards. So then we looked at the demarcation line. We found that it was best with the 3 and the 9 milliwatts. So then we seem to understand one thing, but why is it was not so effective with the others? It was essentially that in this more accelerated cross-linking with higher fluence, the depletion of oxygen was not being adequately replenished. And for a active cross-linking, we need an oxygen-rich environment. So then came in the concept of going in for a pulse cross-linking, wherein there was a 1 second on, 1 second off, which seemed to show that there was more effectual cross-linking here. So then we came to understand, yes, the best ones were the 3 and the 9 milliwatt protocols with better demarcation lines and better evidence on electron and confocal microscopy. And probably pulse irradiation is also effective enough. While all was said, there was a resurgence of information of customized cross-linking based on the premise that keratoconus is a focal disease, and if you could concentrate high fluence over the cone and lesser over the surrounds, it made sense. And at this point of time, the Brilliant microscopy also told us that the viscosity was lower in the focal area where there was active keratoconus than in the surrounds. In fact, the surrounding area could have normal viscosity based on the focal diseased area, as was shown in some more studies. So then it seemed to make sense that if you could use energy levels at differing levels, which would stiffen more the weaker area and less the surrounds, it might even reshape the cornea and make it better as far as visual quality and acuity was concerned. And we did our own study where we found that when we compared the two in 30 eyes, the endothelial counts were stable, the inferior superior asymmetry had definitely improved, so also the higher order aberration, and the specular microscopy was not affected by using this higher energy. So with these supports and disbeliefs as we moved on, what constantly bothered us that we do not have an ideal biomechanical measure as aura nor corvis was as authentic as we wanted it to be. We also knew that the 30 and the 45 milliwatts were definitely not the way to go. Then came a thought, why not look at adaptive fluence? If you could alter the fluence and if you could alter the duration, probably we could use different fluences for different corneal thickness. But then it opened up a Pandora's box. Does that mean that we could cross-link and stabilize a 250 micron cornea? Does it mean you would use just one riboflavin solution instead of n number of solutions which are being suggested? But then the Brilliant microscopy was not able to substantiate as much as we wanted. And we were again challenged in the young eye, wherein although we knew that we would cross-link if there was progression, we knew that the progression was rapid in the young and there was no defined protocols. We had to do it at probably the first instance to halt the progression of keratoconus, and probably a repeat cross-linking may also be necessary. While all this was happening, there came in the topo-guided PRK, which seemed to be promising a lot in the sense that it regularized the cornea, improved the quality of vision, and also provided cross-linking. And there were a whole number of exponents who came with promises that this was the way to go. In other words, it made the cornea more flatter, and this seemed to better withstand the biomechanical stress, and this combined with cross-linking seemed to be promising. But then, could you use a smaller optic zone, or would you really hold on to the golden figure of exactly ablating 50 micron, or could you go on to 60? Was it not hazardous to a little weaker cornea? Were queries which remained buried at this point of time. Although, taking at this example with a significant keratoconus as this, with topo-guided PRK, the patient's visual acuity actually improved to 6.6. The next query which came up was, would you do simultaneously or sequential? Sequentially did not seem to be answer to the whole scenario, because yes, cross-linking would kill the keratocytes, but then if you were to do a topo-guided treatment later in a second sitting, would you not be removing the cross-linked tissue? And are those lasers, aren't they different for a cross-linked tissue which have differing nomograms? And more importantly, if you were to do a topo-guided treatment first, then it would remove the Bowmans, which would allow better diffusion of riboflavin. So then came up a lot of fingers forwarding, telling us that topo-guided PRK with cross-linking, doing a simultaneous treatment was the way to go. However, there were treatment modifications with different people, the different ablation zone, and the percentage of refractive error correction, and so on and so forth. There was also a query that would you use mitomycin or would you not use mitomycin? It seemed to make sense to use mitomycin because it took care of the haze which could be created by the migrating fibroblasts. But then there were always some unanswered questions like which kind of ectasia would be more predictably corrected, what should be the attempted correction, and what should be the ablation depth was not exactly answered. We also found that the epithelium had a donut kind of pattern in keratoconus. So as against an epithelial debridement or alcohol usage, PTK seemed to be the way to do because it also removed the epithelium and the stroma and in fact regularized the cornea while doing a PTK, and this itself augured for the quality of vision. There was this enigma whereas post-classic ectasia was concerned because there was an essential difference in the pathophysiology of diffusion in these thinner corneas. And we also knew that the flap did not contribute to the biomechanics. So then the other area was, do we do cross-linking with laser vision correction? We knew that cross-linking definitely augmented the rigidity of the cornea. And we also knew that the weakening of cornea in laser vision correction presented as regression and iatrogenic ectasia. And if we could strengthen the cornea while doing the treatment, was it not the way to go? And keeping in view that if we could use a lower lens, the refractive effect was not noticeable. And so, with some doubts, LASIK Extra came to hold its own stand with using a lower fluence and a lower duration of treatment, with a clear understanding that we do not cross-link the flap. Then again came the question of the eccentric and the centered cones. We knew that for eccentric cones, intact was the way to go. But would you use a single segment, a dual segment, which is more promising? Would you want to do a focal treatment? Would you want to have a global treatment? Would you like to cross-link with intacts in the same sitting, or would you do it sequentially? It seemed to promise that doing it in the same sitting was actually probably right, because the newer dissected femtosecond channels allowed more pooling of riboflavin, and which brought in a greater flattening effect of cross-linking. And again, there were a huge number of articles which told us that this was the way to go, but the debate continued. All this was happening when so much of understanding was going on. There was one study which was coming up that actually it's only rubbing of eyes which was the trigger for progression of keratoconus. And if you could just control rubbing alone without cross-linking, that in itself was a treatment. There was also an understanding that if keratoconus was seen in allergic eyes, we need to be very aggressive in our treatment. And more so if there was limbal stem cell deficiency, transepithelial cross-linking was only the way to go. And then when we're stuck with scarred corneas, it was only DLK. We need to keep the risk of rejection in mind and the whole thing which came up. So in essentially, although in the last couple of days, decades, we've been doing cross-linking, we've come way, way forward, but the controversies are still there. We are still in the process of evolution in understanding. Yes, there is a definitive crossroad which we've reached. We have a bit more optimal best corrected visual acuity today, but then there is a lot to think about. Thank you.